Good afternoon. For those of you who had a little problem hearing me, I do apologize. I do not have the best video feed to offer you today, but I just want to say thank you very much for attending this special briefing for the Bureau of Emergency Services and Fire Prevention in regards to incident number 2017-4-23-10. Want to make a little introduction. Some of you know me, some of you don't. I'm Craig M. Johnson, Captain of the Emergency Services Unit, commanding officer, obviously, for all emergency responders within the realm of paramedicine. And this briefing is brought here due to the events of April 23rd, 2017. And I want to go through a couple of things with you. First off, why we're here today. To start off here, this is a response to an accident that occurred on the 23rd of April this year, approximately 10 a.m. A young man, aged 28, lost his life from serious injuries resulting in traumatic MOI, or mechanism of injury. Our department was cleared of any liability and wrongdoing of the incident. The injuries he sustained were of the incident, and the department was not involved in this whatsoever. His chance of survival in the incident was less than 1%. When this event occurred, some things came to light, and although the patient unfortunately did pass away, we've learned a couple of things from this that, well, we have to say what went wrong. Well, what did go wrong? Quite a bit went wrong, if you were to ask me this directly. First part that went wrong is that prolonged on-scene time due to a large patient and a lack of manpower on scene. They were also unable to get intravenous access and unable to intubate due to clenched jaw, which is common in traumatic injuries, and there was no portable HRS tool available. The first and the last one, the on-scene time and the HRS tool, that is actually being fixed as we speak right now. Another problems that came into here was the aftermath of the incident. Information was given to the press without authorization from an unassociated unit that was on scene, but was actually not associated with the incident. They were, I believe it was traffic control of some sort. They were trying to keep vehicles away from entering the scene because there was a DOA involved. The information was inaccurate and was a violation of department policy, and it was actually a violation of federally mandated HIPAA laws. The individual at fault was only given a verbal warning. To me, that says there's lack of a sound disciplinary policy that we are in effect for. Because of all this that came forward, I'm here to you today, the Bureau of Fire Prevention, to look at a few different recommendations and changes for the field, as well as one major communication breakdown that came apparent. And all of these changes requested are result in a breakdown of communication or lack thereof. First off, there's a need to reorganize of heavy rescue resources, which is being implemented as we speak right now by the Deputy Chief of Operations, Chief Williams, whom you all know. New equipment on the light patient rescues, and new in-house policies and disciplinary actions for violations of HIPAA policies. So, to start things off, I don't want to bring the carriage before the horse. What are we lacking as a department to make better decisions on scene for patient care? First one being is the focus of changes for light rescues. In this case, is for those of you who don't know what light rescue is, it's also called an ambulance. Rapid intubation tactics availability. We've had very few. And for this is for an arrest without a clenched jaw. This is actually called the LMA, laryngeal mask airway. It's a simple device. It's inserted into the glottic opening or mouth of the patient. One inflation, and it opens up. You pick tube 1. If you ventilate it using a BVM, and you take the mask off and you can hook right up the tube. If you hear lung sounds, great. If you hear belly sounds, switch to tube 2. And 9 times out of 10, you're going to be pushing now air into the lungs. helping the patient breathe or ventilate them. The second thing we're thinking about is a patient with a clenched jaw issue from a traumatic arrest or injury. Now, with the clenched jaw, which is what this patient had, this could have given us some better chances of his survival. In this case, it is needle cricothyromy kit. For simpler terms, it is a cric that you see about in the military, where they do a tracheotomy, they cut you open, they insert a straw or a tube. In this case, it's a sterile controlled tube kit that, if you can see here, it's got a burst jet insufflator. Push the syringe in, it blows up, and it holds the airway to your control, so you can actually intubate. However, neither one of these proposed devices should replace the endotracheal tube. The endotracheal tube is a short and long-term solution for patients who are going to be on a ventilator. In this case, traumatic injuries, motor vehicle accident-related cardiac arrest. The endotracheal intubation should be first used. If difficult administration presents itself, the alternatives that I've just given you should be used. And now there's more focuses on the changes. In this case, the patient had a problem with intravenous access. This is a big problem because we need to administer medications to this patient quickly. In this case, epinephrine. The sooner you get epinephrine, the sooner it can be beneficial for their safety and life. So, I want to present the next device to you. IV access is needed and oftentimes unattainable, so I want to give to you rapid intravenous infusion. Can matter and save lives. This is the Aero Easy IO or Aero Easy interosseous device. Now, what interosseous is that this is an IV device that actually gets screwed into the bone. And I actually had someone dispute, well, Captain, this is extremely painful. Not when you're in cardiac arrest, you're not going to feel it, unfortunately. This device can provide life-saving fluids, life-saving medications, and provide easier stabilization, I should say, to a patient who is indeed critical. There's no issue with trying to establish an IV. You go right into the bone, and what a lot of people don't realize is that all of our blood circulates through our bones throughout our body. So by using the Easy IO, we have instant access. Drill right into the shoulder or the tibia tuberosity of the knee. Now, why all these devices are coming forward? What it turns out is that we have a lack of communication. And this lack of communication is paramount. And it's not anyone's fault, really, except our own. Medical Control is our resource center that actually does all of our standing and online orders operations. If Fianl Medic calls in, he needs a specific order, he calls in to get it. The problem is two things. There's two problems with this. One, we have way too many online orders. Online orders is where we have to call in and get verified an allowance for those orders. Sometimes they require a doctor's signature. Another problem is that the staffing in Medical Control, there's only 3 of them for the entire district. That is way understaffing. Now, that composed with the call volume we do for a year, understand that critical orders are 75% all online. 75%. That means for having a critical order, I have to call someone to make sure I can get that order or get that medication or airway adjunct or pain relief. I have to call. Now I can understand that, but as medics, we're trained to do all these to begin with. Why do we have this additional checks and balances when you go through medical school, you learn all these things? It's part of the basic curriculum. So that was one of the communication breakdowns, is the fact that there is a complete lack of. That it's not Medical Control's fault, it's not the Fianl Medic's fault. If anything, you can put it more towards me. I believe that we need to move forward as a department. In this case is removing most of these orders that are online and going and retrain medics and putting them through standing orders. Now, what are standing orders? Standing orders versus online orders. Well, standing orders means If they meet the criteria of what you're trying to do, you can do it. Online orders are, if they meet the criteria of what you're trying to do, you still have to call for this. One thing to understand is, a good example, morphine sulfate. This is a controlled substance that we use for pain relief. Morphine sulfate requires an order. We are not changing that. I do not want medics just pushing morphine because they say they're in pain. No. This is a medical control decision, and it should be allowed for... now let me just back up 1 second, because morphine sulfate is a standing order for someone who's experiencing a myocardial infarction or heart attack. If that's the last line, if that they have an ST elevation with chest pain, radiating, cool clammy skin, we're going to give 2 morphine sulfate. For pain relief, we still need to call. It's standing for a cardiac issue, but for pain relief, we have to call for it. The dosing's the same, but there's 2 different purposes served. One is for pain relief. One is for bronchial and carotid dilation throughout the body. So, airway management is a basic life support skill. Should be standing orders. So all the airway adjuncts that I just showed you should all be standing orders. The Aero EZ-IO should also be a standing order. Medical control medics need to understand that field medics are under stress and need to have quicker reflexes for what they do. Quicker reflexes is that they need to be able to, it should be reflex. It shouldn't be a methodical, slowed down process. This is emergency medicine. There's nothing slow about it. There's nothing slow about getting there. There's nothing slow about treating the patient. Paramedics do things that nurses can't do. That is why we need to be able to have that freedom to be able to do certain things. To go moving forward here, that after we've changed all these things, we still had a problem with the breakdown with communication of, or over communicating with department policy concerning a press release that was given out. Press is always looking for information for nightly newscastings. You can find press anywhere. You can find them at large incidents. Structure fires, motor vehicle accident, mass casualty incidents. You will always see someone from the media there. And it's their right. It's their constitutional right, freedom of the press. You know, we always hear everyone talk about that. And but there's also something that with the press that is still in its infancy. I mean, it's less than 20 years old. Is understanding HIPAA laws is the first step to working towards just a commonality of what the media can say and what we can say as a department. You know, the press can and will take information out of context. It's happened before. So HIPAA, you saw on the last slide, what is HIPAA? Anyone venture to take a quick guess? Okay. Health Insurance Portability and Accountability Act. These are privacy safeguards for all medical information pertaining to confidentiality. No one is allowed to know what is wrong with you unless you authorize them to. And the only people that can know without your authorization are doctors pertaining to treatment. The doctor is saying, I'm going to go speak to a trauma surgeon about your broken leg. Well, that's fine. It's kept confidential. Because even the doctor says, I have a age of the patient who's a male or female with a broken femur. This is what happened. He's not sharing any of the personal information. He is sharing the care information of what he's proposing and what he needs. And that's when they can bring them in on consult. It's a little bit different in hospitals. In the field, it's much more different. It prevents misuse or release without consent. Your information is private. It should be kept private. An example of this is in 2016, New York Presbyterian Hospital sued for $2.2 million and they lost. I think the original suit was for $3 million, but for $2.2 million they lost for filming 2 patients without their consent. When we found out about it, one patient was tragically died due to the injuries sustained. However, the other patient and both families sued New York Presbyterian, and the judge awarded each family $1.1 million. It's no joke for paramedic or medical responders. I've heard of them losing their homes. Privacy communication violation is a crime, can and will be punished. Corrective action for public relations. All information requests need to go through the public relations office. Communications will not include name, address, or medical ailment. We can't tell you that, yes, you went to the hospital for a bloody nose. Say a medical emergency. I have no problem giving vague information. I have no problem with it all because it protects the patients that we serve and the public that we serve. Statement can only include gender, bracketed age range, elderly, adult, child, no specific ages, and that they requested emergency assistance related to a motor vehicle accident, fire, or a 911 emergency. All other information will be released upon approval of the family. That is going to be a written statement. Police may release at their discretion for criminal activity. That is different. If the patient was wanted for criminal activity, the police can do whatever they want. And we have told them that we will stand behind them because when it comes to criminals, there's always being looked for. So that type of activity will be looked after. Fire department will only release information with written patient request or POA notarized. Power of attorney. Some patients have a power of attorney. They control all of that patient's rights. The person who is the power of attorney for that could be a sibling, a child of the patient, like a of-age daughter who's over 18. They control those patients' custodial rights. Disciplinary actions for HIPAA violations. The CBA is on board with corrective actions. Various suspensions of employees who violate this policy. Okay, if you violate it, there are suspension levels that are going to be coming out within the next few months. Once I speak to the CBA a little bit further of what type of agreement there is. Release of patient information, correct or incorrect rumor, will not cover individuals criminally from legal complaints. The department will not cover you if you violate these laws. We expect this to cause swift changes because we will not cover a patient for violating legal laws. We'll have to take it on our own. So you can be suspended, lose your job, lose your home, you can lose everything. These laws are serious. Fire department will cooperate fully with all investigations, and the likelihood of violations in the future to be limited or non-existent because we're taking a hard stance on patient protection at this point. So this is all some of the background information that I received. Are there any questions for anybody with these proposed changes that we have ahead of time? All right. Thank you very much, ladies and gentlemen. Thank you very much for meeting with me. Should you have any questions, you can reach me at extension 3311, and I'll be happy to answer any questions or talk to you after we break here. And other than that, have a great evening.